It's an honor to come and speak today for Grand Rounds on a topic that's I think is really interesting because it's something that I think about every day, and I'm sure that you guys probably think about it as well, which is, the basics of diagnosing psychiatric illness. Now, this is going to be kind of an interesting topic for a lot of you guys because when I entered into psychiatry and I, matriculated through the program and graduated, I did not really have a very good understanding of the paradigms and framework that we use to essentially cement our understanding of psychiatric conditions. And then from there, how and why we treat certain things. There's an interesting story about what happened to me in my personal life that I want to share as we launch into this. When I was a fledgling surgeon back in 2010, I almost killed someone in one of my ICU rotations in the trauma surgical ICU. And the reason that happened is it was a trauma patient, motor vehicle collision, polytrauma, traumatic brain injury, a lot of abdominal injury, a lot of orthopedic injury, et cetera. And I was the resident who was taking care of that individual as an intern. And me being the neuroscience, neurosurgery resident that I was, I missed abdominal compartment syndrome in that patient. And the patient coded and almost died, which was actually really scary for me. And I remember Dr. Kokenauer, who was the trauma attending, a very fine physician, pulled me to the side and he said specifically, hey, dummy, you are a doctor first, surgeon second, and neurosurgeon third. And the evolution of your thought needs to always flow in that direction. It cannot flow in any other direction. It cannot start on that end, on the neurosurgery end, and work backwards. You have to think like a doctor, then a surgeon, then you think about the brain. And the reason that I think that this topic is particularly cogent for a lot of us is because we don't always have good answers for and empirical reasons for why we approach patients in the way that we do. A lot of times, the reason that I was given and is that that's the way that we do it. And that kind of betrays a little bit of a fallacy in our approach to psychiatric conditions, because it kind of suggests that treatment and evaluation and diagnosis of psychiatric conditions is might be more culture. And hopefully it'll spark some interesting discussion points. I have a lot of slides, but I'm going to breeze through them because I want to make sure that because this is not really designed to inform you of to kind of inform you of something new necessarily. I think this presentation is more designed to contextualize psychiatric approach and how it relates to neurosciences in general. So, I have some disclosures as listed here, but I think we need to understand why it's important to have a psychiatric framework. So, like I mentioned before, we delve in illnesses that sometimes operate more on a spectrum than they do on a very definitive pathology. So a lot of the conditions that we treat are syndromic or disorders. They're not necessarily illnesses or diseases. And on top of that, there is it's our approach is actually very symptom oriented. So we currently evaluate based on symptoms, and we currently treat then and diagnose based on symptoms. It's kind of like saying that if you have chest pain and dyspnea on exertion and maybe a little bit of jaw pain, then that equals heart attack. So every patient that comes into the ER with those specific symptoms are categorized into the category of having a heart attack. And then we treat the heart attack. And if it doesn't get better, then we go to the second line treatment, which might, or a second line diagnosis, which might be a pneumonia or something else. And that's really the way that a lot of our conceptualization works, and we can tidy it up and we can clean it up and we can put lipstick on a pig. But that's essentially what we do sometimes. And as a result of that, and this is another adage that I state quite a bit, is that a lot of our treatments are kind of like treating sepsis, which is a syndromic condition that requires broad spectrum, wide scale treatments, right? If a patient comes in with sepsis, no matter where the infection is, no matter what the bacteria is that is causing the problem, we treat that patient with fluid suppressors and broad spectrum antibiotics. That's kind of what we do with psychosis, and that's kind of what we do for depression as well. So we're dealing with a very complex system when we deal with the brain in general. But then when you add on top of that, that the neurological disorders that we treat have behavioral and emotional manifestations, then the question that we have to ask is really what is healthy and what is mental health? So is it purely the absence of disease, or is it the same thing? Is it the same thing as being normal? Would you define health as a state of normalcy? Because that's language that we actually use with our patients. Like, does this feel normal to you? And things like that. And even if we might not say it, we usually think about this. Is this a normal reaction to grief? Is this the normal reaction that we would expect someone to have to their dog dying, or is this a normal response to being intoxicated on substances? But then that begs the question, what is actually normal? Because getting a flu or getting strep throat or even getting certain types of cancers is actually normal for the human condition. It's not healthy, but it's normal. It's an expectation. You expect people to get the flu every now and again, or the cold. You expect certain types of cancers to occur depending on your genetic makeup and your environmental factors and your age, right? So I'm sure you guys have heard people say this before, that every woman will get breast cancer and every man will get prostate cancer if they live long enough and if something else doesn't kill them first. So is that normal then? And if we define some physical ailments as normal but not healthy, then what about extremes of emotion? What about sadness and depression, apprehension and anxiety, boredom and ADHD? Where do we draw the line, and where do we, as doctors, come into play in terms of addressing these neurological conditions that have these behavioral and emotional manifestations? Now, this sounds complex from a high altitude view, but we actually have a paradigm of understanding for this spectrum-based pathology that exists in the real world. And that paradigm is actually very simple, because that paradigm involves skin care. So, you can get a tan, you can get a sunburn, and you can get melanoma. A tan, all three of these things, the primary culprit is damage to the skin from sun exposure. Your genetics might play a part into how likely you are to get a melanoma versus a sunburn. For example, I've never had a sunburn. I'm sure there's probably people in the audience who've never had a sunburn, but I'm sure there's people in the audience that are really scared of the big ball of cancer in the sky, because every time they go out, they get a little red and it stings a little bit, and they need extra protection and extra layer. Much like melanoma, though, in psychiatric illnesses, they build over time. So your body, like your skin, takes hit after hit after hit after hit, and eventually the protective mechanisms fail because you reach a threshold, and then you get melanoma. Suntan does not need any medical attention. Sunburn or sun poisoning needs a little bit of TLC, maybe a little bit of medical attention, maybe you need fluids, etc. Melanoma needs pretty aggressive medical attention. You have bought yourself a visit to your dermatologist quite frequently in order to do skin checks to make sure that you don't die from cancer. And much like melanoma, it isn't yesterday's sun exposure that led to this freckle that is suspicious. It's the buildup of sun exposure over years that leads to melanoma. So no patient will come in and say, "How did I get melanoma? I was in my house all day last week." That's not the way it works, right? So how did I get depression if I've never had depression? Well, that's not the way that works, right? The environment is still the environment, just like the sun. You're still taking hits and you're still getting exposure and you're still adapting to it. And eventually your brain, just like your skin, will reach a threshold and you will develop some kind of a neurological disorder that we classify as a psychiatric disorder. So the way that I look at things is that, we have to kind of look at where do we draw the line as far as when we need to intervene? So are our symptoms a tan, a sunburn, or in a melanoma? And to really delve into how we approach treatment, we have to understand how we diagnose and why we diagnose the way that we do. And so I want to focus the first half of my talk on really the history of psychiatric diagnosis. This might be new to some of you. This might not be new to others. And if it's not new to you, then wonderful. Just hang out, have a good time. Maybe there'll be a refresher course. But if it's new to you, then I think that you'll find these next few slides pretty interesting, because the history of psychiatric diagnosis is actually rooted in taxonomy, and it's not rooted in biology. And this is betrayed in the name of the DSM, which is the Diagnostics and Statistical Manual, because the reason that that classification system existed was for statistics. And it started in the pre-neuroscience era, but post-theological era. So this is around the 1800s. And what we see is that in the United States Census, the 1840 census specifically included a checkbox, and you can kind of, this is the best picture I could find of the original document, so it's a little bit blurry, but you can see that there's a checkbox for insane and idiotic in the 1840 census. And this was actually the first attempt in the United States to classify any type of mental illness. Now, why would this be important? Well, at that time, there were insane asylums, and that's where people were. Insane asylums needed funding. And in order to appropriately fund insane asylums, you needed to know who was there and why they were there. And so this was for allocation of resources, not so much for classification of symptomatology and understanding and conceptualizing illness. And what's interesting is if you look back, if you think about this 1840 document, the census, insane and idiotic, in most states in in America, this paradigm from 1840 still exists, right? So when you do a mental inquest warrant in emergency psychiatry, for example, you have two portions of that. You have the mental illness and mental retardation. And they say retardation because that's how it's codified in our state laws, even though that term has fallen out of favor and not in vogue anymore. But this exact paradigm, this understanding, and this classification system of insane and idiocy, quote unquote, exists today. So this has not changed. And this is why understanding the background becomes so relevant for our understanding of why we look at things the way we look at. The other reason that it's important to understand the history and the classification of the history and the trajectory from classification, taxonomy, statistics to diagnosis is because the census was used for purposes that were somewhat nefarious. So, for example, a lot of the African American populations were labeled as such because they used the census to determine voting and determine who's eligible and determine a lot of other things. And a lot of folks who were, and this is around the Civil War era, a lot of these folks actually were disenfranchised because of the way that our system, our inherent system, classified them. Another important thing to note is that around the same time that this was going on in 1844, the superintendents, the medical superintendents of the U.S. insane asylums got together and formed the Superintendents Association, which is the predecessor for the American Psychiatric Association. And it actually predates the American Medical Association by about 20 years. So the AMA was formed around 1860, but the predecessor to the American Psychiatric Association was formed in 1844. Just to give you an idea of the marriage between psychiatry and society and politics, because we know that psychiatry and law is married, but psychiatry is actually married so intimately within the infrastructure of American politics and American social understanding that our organizations actually predate the Organization for General Physical Medicine. Now, thankfully, the census did expand its classification system over the years. So in 1888, for example, the U.S. Census Bureau added a few other categories of mental illness for categorization purposes. This included dementia, alcohol use disorder, which was called dipsomania at that time. It included some neurological conditions, epilepsy mania, melancholia, which is depression, monomania, which is probably what they thought was psychosis or delusions, and then paresis, which is actually syphilis. So they added some categories and some other symptomatology, and also the Superintendents Association went through an evolution to be called the Medico-Psychological Association, or AMPA. And the AMPA actually developed a plan to gather the statistics from all the mental hospitals, which were actually insane asylums, so they could see who was in these insane asylums. But they worked with the National Commission under the Census Bureau. So the purpose was still not diagnostic. The purpose was still administrative and economic. I put the dates on here for when some specific transitions happen, but a really interesting thing that happened was the standard classified nomenclature of disease, or what was called the standard at that time, was published in 1933. And now this was for diagnosing inpatients with severe psychiatric and neurological conditions. So the standard, quote unquote, standard was developed so that individuals who were working in these insane asylums could diagnose individuals, again, for administrative purposes. So it was still not the diagnostic process was still not there for patient care. It was there for statistics and gathering data along this time. So in the early 1900s, what was the state of affairs in the United States? So in the United States, the standard was being used, and most patients that had psychiatric illnesses were treated in insane asylums. There was not a consistency of nomenclature or of wording or of a diagnosis. And that made it very difficult for individuals, professionals like ourselves, to communicate with each other. That made it very difficult to gather data and research because each area of the United States has its own interpretation for how they would use the standard. So it was kind of like the U.S. Constitution. It was open to interpretation, and you had some judges, which were doctors, and they made the decision on how to interpret these specific things that were listed out. And so it was very hodgepodge and not a very organized system. However, when you went overseas, then Kraepelin was doing something a little bit different. He was describing symptoms in Europe that were more symptom and time course based, and he put that in his compendium. And I would really encourage, if you haven't read excerpts from this, I would really encourage that everyone do that because it's a very fascinating document, and some of the descriptions of illnesses that he has in there are pretty relevant today. Just to kind of give you an idea of where he was at that time compared to where we were in the United States. Now, around this time, there was like a nuclear bomb dropped on psychiatry. And so we're going to do a brief non sequitur because I think it would be impossible to continue any conversation on diagnosis of psychiatric conditions unless we also talked about Voldemort or Sigmund Freud, if you will. So Freud is actually very important to discuss whenever we discuss anything regarding the history of psychiatry, both in the United States and abroad. And the reason that it's important is because what he did, and I'm not going to go into a soapbox or a tangent on this, even though catch me over lunch or dinner, and I'll talk about this for hours, much to your chagrin. But what he did was he actually changed the way that we conceptualize mental illness. So remember that there were insane asylums. Insane asylums were in kind of the rural areas. And so you had no reason to have a psychiatrist in a city environment. There was no point because the clear demarcation of sick and healthy was institutionalized or not. And what Freud did is that he allowed psychiatry to leave the hospital and be an outpatient practice. So before Freud, if you were mentally ill, you needed to be hospitalized. After Freud, everyone was to some degree mentally ill. And so he really blurred the lines between mental illness and mental health. And the quote that I love is actually a quote by Menninger, who founded the Menninger Clinic in Topeka, Kansas, which was that the purpose of psychiatry was to get folks weller than well. And this is where the walking well adage comes from. And psychiatry really took on a very different approach and a different transition with the introduction of psychoanalysis and Freud, which was actually just theory and not really medical practice. But it took hold because there was a kind of a mutually beneficial relationship between psychoanalysis and psychiatry, because psychoanalysis allowed psychiatrists to leave the institutions and the insane asylums. It allowed psychiatrists to kind of rub elbows with the rich and powerful. It allowed folks to be kind of the consiglieres of society, and take society's secrets and tell people why they think the way that they think, even though it was all theory and none of it was based on any evidence whatsoever. And the way that the analytical movement took hold was very rigid, and I'll talk about that here in a bit. But this is a very important paradigm shift because now sickness and health were blurred. So everyone had a neurotic reaction. Everyone had some issues going on with the way that they were raised or what happened that caused some problems, even if they were normal, even if they were healthy. But the impact of Freud does not just extend into the way that we conceptualize illness, but it goes beyond that. Have you ever thought about why we do 45 or 50-minute appointments for therapy and why the therapists used to sit behind the patient, not looking at the patient? I have. And the answer that I got was actually a later justification, which was, oh, it's to avoid transference. You need to be a blank canvas. You need to do this or that. And so that the patient has the ability to kind of just say anything and not respond to you. That's all BS. The reason it existed that way is because before Freud wrote anything about psychoanalysis, he was actually a hypnotist. And the way that he hypnotized people was that they would lay on a bed, he would stand behind them, put his palm on their forehead, and try to hypnotize them. So that's why we sat behind. And so he just continued that habit that he had, and that got codified into the language of psychiatry and the practice of psychiatry. And so that's what people did for decades. So it had nothing to do with transference. Transference was actually a later justification that was published a lot later than when this started. And so what about a patient that comes in and says, hey, I want a practical treatment for my mental illness. I do not want to look at a wall while a guy who smokes a pipe or a cigar behind me just listens and doesn't talk to me. And what if you, as a physician, wanted to treat that? Well, if a patient said that they wanted practical treatment, actionable items, well, that's resistance. The patient is resistant to our psychoanalysis. And what if you as a doc want to actually do something more active? Oh, this is just an anxious, nervous response that you have to the patient. This is your countertransference. So that's how this developed for a long time. And the impact of analysis in the understanding of psychiatric conditions was ego and economically driven. And what do I mean by that? What I meant by that is that psychoanalysis individuals, physicians, understood that in order to gain influence, they had to be in academic institutions. And so they went there. They got involved with the APA. They got involved in administrative positions in psychiatric departments. And then the idea was that you either conform or die. So let's imagine the landscape here for a second. So if you have a program director or a chairman who is a psychoanalytically inclined, then you have to do psychoanalysis in order to be a psychiatrist. Some of the folks here will attest to that who are alive who were practicing during that time. That most psychiatrists and residents went through analysis themselves, and most psychoanalytics you have to go through analysis in order to be an analysis trained psychiatrist. So isn't that a self-selection bias? So what if the guy who's responsible for your entire career has to be convinced that you believe in his paradigm in order for you to get acceptance into this into the field? Well, obviously, you're going to self-select for individuals that want to do that and believe in that. Obviously, you're going to challenge anybody who challenges you and squash that. And obviously, you are going to then create an environment that treats any kind of brain-based and empirical brain-based paradigms of thinking and empirical evidence with disdain. And we saw that because the NIMH explicitly forbade any expenditures on mental institutions like psychiatric hospitals and on biological research. The mindset of individuals around this time was that we are treating conditions in society, and therefore, if we that's what we want to address. That's what we want to know of. We don't care about what's going on in your brain. Tell me about how you are interacting with things. And so it really went in a significantly weird direction. But there was some bastions of sanity during this time. One was actually the military. So we needed to classify mental illness to determine fitness for battle for World War II. And when the military looked at psychiatry, they saw that everybody was sick. And then they looked at the fact that some people were, some areas of the country, there was a lot fewer rates of mental illness than others, but the people looked the same otherwise. So there was no consistency in the way that diagnoses were being handed out, or in how who was fit and who was not fit. So they created what was called the Medical 203, And this was a little bit more empirical in nature, and this was mostly ignored by civilians. But there was a couple things that happened in the post-World War II era. First of all, a paper was published that stated that if you had a patient with a number of patients and had three independent individuals, psychiatrists evaluate them, they only agreed 20% of the time. And so the need for some consistency was present, and that's where the DSM-1 came in. The DSM-1 took what the APA was doing and took what the military was doing and took what Medicare and the insurance companies were doing, compiled all that together, and came up with a statistical categorization of mental illness. It was not used clinically in public, but it was there. And it was rooted, however, in mostly psychoanalytical theory and not in any kind of evidence. And that the stigmata of that is there because they looked at because a lot of these syndromes were defined as reactions rather than disorders. And the DSM-2 also came out, but was not much different. Both DSM-1 and DSM-2 still relied on descriptors of illness. And as we know, descriptors tend to be a little bit subjective. And so there were inconsistencies that were there. Now, what ended up happening, though, is a paper got published. I believe the guy's name is Rosenthal here. And he published a paper called On Being Sane in Insane Places. I'm sure you guys have heard of this before. Sent completely mentally healthy individuals to hospitals. They got admitted. They got treated, and they would not be were not released for like a month or so. And he published a scathing paper stating that psychiatry doesn't know what it's talking about. Then what he did, he was challenged, Rosenthal was challenged by other psychiatrists and say, now that we know you're doing this, send us some more people. And he said, okay, in the next 6 months, I'll send you a couple people. And they said, oh, these are the 3 people that you sent. And he came back and said, I didn't send you anybody at all. So more proof of the fact that you don't know what you're talking about. And so they obviously, when you have a situation where you're not going to know who's sick and who's not, and you create this inconsistency and mistrust in the community, then you are going to give birth to anti-psychiatry movements, which says, all right, if no one can tell if I'm mentally ill, am I really mentally ill? And if mental illness is not really real because no one can tell that I'm mentally ill, because even the psychiatrists, the experts don't agree on what's going on, then why do I need doctors? Why do I need a doctor to do therapy? Why can't a therapist do therapy? Why can't a social worker do therapy? Why can't a psychologist do therapy? And if mental illness does not exist, and even psychiatry says that these are more social kind of problems, then isn't involuntary hospitalization kind of like slavery, that we're just putting them into these farms and things like that? And so we must abolish it. We can't just change it. And so that's really created a big problem. Now, around the same time that this was going on, a paradigm shift was occurring in the Show Me state, or Missouri, where a research diagnostic criteria was being developed, and this is called the Feiner criteria. Dissatisfied with the state of psychoanalysis, an individual called John Feiner, a physician, cataloged using clinical descriptions, delineation from other disorders, some laboratory findings, follow-ups and family histories, etc., compiled a diagnostic framework to be used in research. And I want you to remember this for later. But he created this, and this happened to be the right place at the right time because we needed a DSM-3 at this time. Because with the anti-psychiatry movement, a mistrust in the community of psychiatry and mental illness, people were not getting treated because psychoanalysis wasn't treating them, and because now there was a doubt in whether mental illness was real or not. And also because of that, insurance was saying, do we need to fund something that the folks who are treating it don't really know what they're doing? And so the DSM-3 came out as a response to that paradigm. It came out to to satisfy the dissatisfaction in the public, to address concerns of insurance, and also to try to transition and evolve folks, the understanding of illness from descriptions and reactions more to disorders and illnesses. And it changed the idea of psychiatry from being a social or cultural label more to a medical condition. Now, you all know that this stigma still exists today, but the DSM-3 tried to shift that. And what I think is really important to understand as we look at DSM-3 and beyond is that it relied on the ingredients that were already present because it tried to shift a culture. And the problem with evolution is that it relies on the ingredients that are there. You don't evolve from a monkey to a fish within a generation or two. You can have a primordial substance that then branches off into monkey or fish, but it's very difficult for a monkey to go back to being a fish, if that makes sense. So I want you guys to keep that in mind, is that the DSMs have tried to kind of meld the statistics of the Census Bureau and also the stigmata and the culture of psychoanalysis to create this chimera model of understanding psychiatric illness, which is what we use still today. So we are still kind of dealing with that. And a proof in the pudding of the fact that we are still dealing with that is that until DSM-3, homosexuality was still considered a mental illness. In fact, the Feiner criteria even had homosexuality in there as a mental illness. Now, we all know that that's not a mental illness, but back then that's what they thought. That was codified as a mental illness, and which kind of supported conversion therapy and all that other crap that still exists to us in some iteration today. And so I want you to keep that in mind, that when we think about some of these psychiatric labels that we use, like borderline personality disorder, et cetera, et cetera, et cetera, some of them might be real, but the same people who talked about borderline were the same people that thought that being gay was a mental illness. So how much faith can you really put in that concept that, oh yeah, this is just borderline, this is just that, this is just this, that, or the other? Which I'm not saying that those aren't conditions, psychiatric conditions. And what I will argue later is that things like borderline personality disorders, things that we don't really understand, are still psychiatric conditions. They're not personality disorders, but that they are just, we just don't know what they are as of yet. So with the DSM-4 and 5, we got something like this. I'm not going to talk about this. You all know this, but it was a checklist and symptom-based approach to treatment. And this was appropriate as an evolutionary perspective from where we started, given the times and given the context, but it still does not really reflect reality. Because what this is, because what the DSM is an evolution, but sometimes you don't need an evolution. You actually need to start from scratch, because an evolution, like I said, still relies on the substrate that it was given. Evolution can't create a completely separate creature. It creates a different version of the same creature that's there. So what are the pitfalls of evolving in this way? Overlap, all right? So we talk about this quite a bit with depression and anxiety. We talk a lot about this with ADHD, that there's a lot of diagnostic overlap and symptomatological overlap. And so what ends up happening is, we tend to overdiagnose, because an individual whose symptoms all fall kind of in the middle here has both depression and anxiety, both anxiety and ADHD, and this, that, and the other. And so you get this laundry list of psychiatric diagnosis. And of course, we can't help that. That's kind of how our trajectory as a field took us to. And so what ends up happening is we have a mental illness, but because we cannot conceptualize that mental illness in the framework or paradigm that we have no choice but to look at it in this two-dimensional view. So we're looking at three-dimensional objects, and in the case of psychiatric illness, where time is also a factor, we're looking at four-dimensional illnesses with our limited scope. So what do we do now? So if we're here, where do we go from there? Well, an interesting idea here is instead of building on the DSM, what about us taking a look at the brain itself, which is our organ of interest? Why don't we take a look at that? Our current diagnostic paradigms are rooted, like I mentioned, in politics, in history, pop culture, even. Things like, oh, this is anal retentive, or, things like that, or which is, again, Freudian terminology. So it's rooted in those things, but what it's not rooted in is science or biology or physiology. And we know that. I don't think that's even up for debate anymore. So when we're trying to understand the brain, then we understand the brain from a microcosm, which is synapse, up to a network model, which are circuits. And then we try to understand how symptoms tie in to this structure in our bodies, which is the brain. But we have had a lot of trouble tying the areas of the brain, circuits in the brain, with symptoms. And this is not new. We've had this for a long time. And the attempt to do this is also not new. And because we have such heterogeneity, because the brain is like a mesh of wires that overlap, and they all have nodes and circuit breakers, and the wires all go to different places, and a circuit breaker is not neatly tied into one room. It actually controls multiple plugs in multiple rooms. And so you have a very complex system that we're working with. But, since the 90s, people have tried to correlate some aspects of frontal lobes and brain anatomical structures to mental illness. And this has been done with anatomical studies and postmortem studies. This has also been done with studies looking at brain structure from a radiological perspective, and also from a functional imaging perspective. So this is actually one of the earliest representations of trying to identify a brain-based understanding of illness. And believe it or not, was actually published in a very high-impact academic journal, this little crude hand drawing, because even in the 90s, our understanding was this crude. It looks like a kid's drawing of the different pathways that we deal with. So the idea became that, okay, we know that there might be, based on these studies here, some correlation between the brain and some correlation to behaviors. But are these behaviors localized anatomically in hubs, or do they travel? And what's the evidence of there being wires that connect these hubs that are linked together and work together? And this was actually also proven by the traumatic brain injury literature, because the TBI literature showed that if you had discrete damage to certain areas of your frontal lobe, you'll get some behavioral and emotional symptoms. But if you have damage to a completely different area where there is a white matter tract, you'll get the same darn symptoms. And so we know from TBI, traumatic brain injury data, that our behavioral structures in our brain are localized and organized in both hubs and roads or tracts. So we have some correlation with structure of the brain. But what about some correlation with function? So we have a behavior has structural correlations. What about functional correlations? And it turns out that if we look at functional brain imaging studies, then we can actually identify some functional patterns of certain types of behavior and certain types of illnesses. And the idea behind this is actually really interesting, because it speaks to bandwidth. So your cerebral blood flow doesn't change no matter what you do, whether you're sleeping, whether you're studying, whether you're concentrating, whether you're vegging out and watching Netflix. Doesn't matter what you're doing, your cerebral blood flow doesn't change. The percentage of your cardiac output that goes to your brain doesn't change. What does change is where that blood actually goes. And so the two main areas, the two main networks or brain functional statuses that were identified was rest state, which was called the default mode network, and then task state, which was called the salience network. And those are just two. So if you're doing something, your brain blood flow in your brain shifts. If you're doing nothing, your blood flow in the brain shifts in this direction. Same amount of blood flow, it just shifts, it just moves. And so it's a dynamic environment, it's a dynamic circuit that we're dealing with. Now, these are just two of the main circuits in your brain, but there are also microcircuits that are happening. And so how many are there? Well, we don't know yet, but that's the whole point of this lecture, is that it's okay to not know. But what we are aware of is that there are intrinsic and extrinsic structures that are responsible for brain systems, whether they're task-oriented systems or non-task-oriented systems. And we know that the intrinsic structures, which are your standard structures, that's your iOS, that your iOS controls or can influence the apps that you download on in your computer, which is your and the apps that you download are your extrinsic brain networks. And so the intrinsic brain networks that have absolutely nothing to do with what you're doing, they are kind of active, they're your default programs that are installed into your computer, are identified, and there are 6 that we have identified so far. But there are also extrinsic networks that these networks work with in order to impact behaviors, emotions, etc. So how do you operationalize this? How do you operationalize that information and the data that's out there? Well, the way you operationalize it is by adjusting the understanding of behavior from a symptom-based pathology to more brain-based pathology, is to recognize, okay, these are the networks that have been identified and codified. They are subject to change. This is science after all. However, we have evidence to suggest that there are specific hubs and tracks and flow and connectivity of the brain that is different with certain types of disease states and certain types of disorders. And maybe the focus of how we understand psychiatric illnesses needs to transition away from the end manifestation of what I'm seeing to the physiology and pathology in the brain. And what you'll notice is if we do that, the language that we use changes. So for example, we stop talking then about worry. We start talking about specific things like rumination, anxious avoidance, negative bias, etc. So when we evaluate patients with a brain-based approach, we're not using a DSM checklist or a PHQ-9. We're trying to identify which circuits that we, at least for now, know might be involved in these psychiatric disorders that we are dealing with, because some of these networks might require different types of treatments in order to address a symptom or a disorder or any kind of decompensation that a patient is dealing with. I'm not, I have about 10 minutes because I want to open it up for discussion, so I'm not going to go into this in great detail, but the purpose of the next few slides is to just identify and show you that there's data. This is empirical data, functional MRI-based data, and other functional neuroimaging data that correlates and supports this hypothesis. So it's not theory. It's a scientific hypothesis at this stage, whereas psychoanalysis and the predecessors of the DSM were all theoretical with no real empirical foundation. And so things like anxious avoidance and anxiety has been also mapped out to specific circuits. Things like negative bias, which you see in some social anxiety disorders, et cetera, is mapped out to certain circuits. Things like threat dysregulation, which occurs also with anxiety, with MDD, with phobias, with panic disorders, has also been identified and has some circuit and brain-based correlations. Anhedonia, context instability. Look at the language. These are not the context instability is probably not language that you have used in evaluation of your patients, because this is now brain-based thinking. It's not symptom and DSM-based thinking, and so on and so forth. Inattention, cognitive dyscontrol, etc. But is this the only paradigm? No, because again, this is science. We have empirical evidence that we're still kind of fleshing out the details of these structures. I mean, every time you pick up the Green Journal, you're going to see some kind of article on neural connectivity, because it's so vitally important for our field to transition away from a way of thinking that's rooted in 1840s and kind of transition into a more modern physician, medical doctor type of thinking. And that's what we are trying to do. And that's what a lot of these researchers at very kind of robust scientific institutions are trying to do. And so, but we do have a starting point of where to begin. Now, is the starting point enough to operationalize? I think so, and I'll explain why, and we can discuss this later. But it's not, might not be enough to completely hang your hat on right now, but it would be unwise, in my opinion, not to use this as we transition into the future of psychiatry, especially with some of the types of treatments that we're coming up with, i.e., vagal nerve stimulation, transcranial magnetic stimulation, deep brain stimulation. You know, VNS is undergoing trials right now, which is a very biological treatment for bipolar depression. In addition to that, also, you know, psychedelics and MDMA, et cetera. Those are all predicated on a circuit-based model of treatment, not necessarily a synaptic model or a psychological model of treatment. You know, the networks that have been studied the most are your salience networks, your default mode networks, and the ones that you see up at the top there with a symptom construct. The global circuit constructs, which is kind of the backdrop, the schema construct, so to speak, are not as well studied so far. So where are we now? So if we know that this is where the DSM is, this is where it took us, but the scientific literature around brain functions and brain structures and brain pathologies in this one particular area, where are we now? How can we use this? Well, maybe we can identify certain types of treatments that are better suited for certain types of network dysfunction. So instead of having an algorithmic model, do therapy, then SSRI, then SNRI, then DNRI, then adjunct, and then mood stabilizer, then lithium, kind of like the way the STAR-D was structured, maybe we can look at this less like factory workers and line workers in a shift where you have to do this in order to do that kind of a situation. Maybe we look at this more like physicians and look at it in terms of, okay, what am I trying to treat? Am I trying to treat, because treating anxiety and depression is not enough. I mean, the reason STAR-D exists is because we know that treatment of anxiety and depression is not enough in the way that we treat it. So maybe I have to change the way I look at anxiety and depression. Maybe I have to think about, okay, are we looking at cognitive control and negative affect and default mode network dysfunction? And if that's what I'm looking at, then maybe my treatments should be tailored to the brain dysfunction that I have deduced and not to the end product. So maybe I should not give a cachectic cancer patient that's a bad example. Maybe I should not give a patient with fever and pneumonia Tylenol in order to treat their pneumonia. Maybe I need to look at the system that's impaired. Maybe I need to prescribe a specific treatment for the specific system that is causing a specific sign, which is a fever, which is the only thing that I can see right now. And so take a step back and look at it. Now, you might wonder, okay, is this actually happening? Who's doing this? Well, it just so happens that the NIMH has come full circle. And when now, instead of not funding any biological based research, they are only funding biological based research. So I brought up the Feiner criteria earlier to show that research-based criteria eventually make their way into the mainstream and into the framework and the paradigm of treatment. And right now, the research-based criteria that the NIMH is using and exclusively using is what's called the research domain criteria. And this research domain criteria is actually supersedes any DSM criteria by the National Institutes of Mental Health. So the NIMH does not care about the DSM anymore. It has recognized that the DSM is irrelevant and antiquated and arthritic and will not evolve in any way that is going to serve the needs of patients. And so what the NIH has done is that it has developed a framework for understanding psychiatric illness that is based on a couple of different factors. The factor of time in the fourth dimension in terms of, the progression of symptoms and the lifespan of a patient, the environmental factors like sun damage from melanoma, et cetera, your units of analysis, which is your genes, your molecule synapses, et cetera, but then also your domains of function, which are your neural circuits. And I would highly encourage, I'm not going to launch into this in great detail now, but I would highly encourage, for the purposes of any psychiatrist who's interested in practicing for the future and not for the past, to read this at length and adjust the vocabulary, because the vocabulary has changed. So we don't really look at things like worry. We look at things like, okay, what is the worry? Acute threat, potential threat, sustained threat, loss, frustrated non-reward. Where is this kind of falling into? We don't look at just depression. We look at, is this a combination of negative valence system of loss and frustrated non-reward combined with a dysfunction in your positive valence systems, which is, your reward satisfaction and anticipation, and how has your learning, what about your learning pathways? How have they influenced your predictabilities and your probabilistic learning and reinforcement, et cetera? And so it changes the way that you approach someone, because these are not ways that we are actually inclined to think, because we don't even know that this is happening. Just like the people that were practicing pre-DSM-3 didn't know that the Feiner criteria even existed outside of St. Louis University, because they were the ones using it, and now we're all using what they used. And so it's kind of important to shift and understand the vocabulary and also what each of these things are, to get a better understanding of the patient, and maybe we can cut down on some of the heterogeneity of what we are treating. So I'm not going to go through all of this in the interest of time, but I wanted to put this out there just so you can take a look at the language and the what these symptoms and thought and what this represents. Now, you might wonder, as you read through all of this, that aren't we just going from one taxonomical structure to another? And yes, we absolutely are. You're absolutely correct. But the difference is that this taxonomical structure is actually anchored in empirical and scientific evidence and not theory. And it's also anchored in your target organ, which is your brain, and not in the manifestations of the target organ's response to a problem, which is the symptoms that you see in your PHQ-9 GAD checklists, et cetera. And so that's essentially what we see here with the domain with the research domain criteria of the NIMH, and talk about the units of analysis that they also use. So this brings up a interesting kind of a point, and which is that, you know, as we move more towards a brain-based approach to diagnostic illness, then we are actually working top down and not bottom up. So we are evaluating patients based on their symptoms, but then trying to conceptualize their illness, not from their symptoms, but from what's going on in their actual organ. So we're kind of working, and then we're treating from the top down, and which is not what we do currently. So what we're trying to do from a different kind of a lens, what we're trying to do is we're trying to see, okay, I got chest pain, I got dyspnea on exertion, I got this thing that looks like unstable angina. Okay, so this is probably the heart. If this is the heart, it's probably cholesterol. If this is probably cholesterol, then in addition to treating the chest pain, I also need to address the patient's blood pressure and cholesterol. I need to also look at the cardiac output. I need to, even though cardiac output is not a presenting symptom that someone will have, no one will come into the ER and say, I have low cardiac output, my cardiac function is reduced. No one's going to do that, but you know to do that because you are working top down, because you are looking at the end result of the organ dysfunction, which is the symptoms that a person comes into the ER with. You're doing investigations now in cardiology and in other sciences that might be lab tests. For us, we're not there fully yet, but we hopefully get there one day. But for us, it's our evaluation, it's our vocabulary, it's our language, it's our understanding of what these networks and systems do. And then we're using that information to deduce what might be happening in the brain. We're still treating the patient, but we're doing it in a more targeted brain-based way instead of a symptomatic way. So instead of giving a heart attack patient morphine and calling it a day and saying you treated your heart attack because the chest pain is gone, you're actually addressing the problem. Because guess what? Cholesterol doesn't treat a heart attack, but it helps prevent heart attacks. And so that's kind of the movement that we are moving towards. So the point of hope here is that, we are essentially where cancer was a number of years ago. And so, cancer was a very negative diagnosis. It was, you heard things like, oh yeah, the treatment's worse than the illness, or what's going to kill you first, the chemo or the cancer, et cetera, et cetera. And we see the same language being used by patients when we are treating psychiatric illnesses. We see the patients saying that too. It's like, oh, the treatment is horrible. They gave me so many medications, this, that, and the other, nothing worked, this, that, and the other. Okay, yes, you're right. That's where cancer was. Cancer was also stigmatized back in the day. But what we're trying to do now is trying to go beyond that a little bit. And we're trying to understand and have a more nuanced approach to our specialty, and to hopefully treat the specialty as a medical specialty and not a social or psychological specialty. And I hope that the talk today inspires you guys to do the same, because I think that that understanding psychiatric pathology from this lens will likely improve your individual patient care that is delivered. So thank you guys for your time again. So I'm Dr. Farooqui. I'm in addition to being in private practice here in Louisville, I'm one of your adjunct faculty members, and work with Dr. Malik as the Associate Director of the Depression Center, and very honored for your attention to me today.
Thank you so much, Dr. Farooqui, for an excellent and thought-provoking presentation. And we'll now open it to questions. If you have questions, you can raise your hand and you will be promoted to a panelist or given the mic to speak. You can also add questions in the Q&A section, and Dr. Farooqui will answer in the order that you guys ask. I can start off the questions. Just I know you have a lot to say about this. The borderline personality disorder that you mentioned. If you can give me just a brief overview of how would you think about the typical patient that gets called that gets with to the outpatient clinic with persistent depression and anxiety symptoms and gets that she has cluster B, he or she has cluster B personality. How would you think about that kind of patient in this new way?
Threat dysregulation, right?
Okay.
So it's threat dysregulation, right? So so I think about it like core muscles, right? So you have your core muscles are your ability to take a hit and not fall down, and your glory muscles, your arms and legs, are your ability to kind of move and do things like that. So, it's very difficult for you to look at and evaluate core muscle strength unless you are able to take a hit, right? And when you look at, even when you think about elderly individuals that suffer from falls, the way that you can tell if they're going to be okay or not is their core muscle strength, actually. And so if you have poor core muscle strength, then your long-term outcomes from an orthopedic perspective are quite low. And so that's essentially what I think that a borderline personality disorder is. I think we call it that because we didn't know what to call it, just like we used to call any non-specific pain syndrome fibromyalgia back in the day. But we know now that that's actually not accurate. Like fibromyalgia is an actual thing. It has some genetic patterns and it has some inflammatory patterns and markers that we can kind of identify. So just because you don't know what it is doesn't mean that it's nothing. And that's kind of the main idea behind how I conceptualize borderline personality disorder. And it doesn't mean that those patients can't be treated, because for the borderline personality disorder patient, maybe instead of trying to find and pigeonhole a very specific kind of treatment, maybe I work on improving threat dysregulation. Maybe I need to kind of boost up their reward anticipation. Maybe I need to give them some dopaminergic agents to try to help bolster some cognitive processes, and some mood stabilizing agents to try to manage their dysregulation. These are all, in my opinion, manageable. They're not obviously, the treatments aren't perfect because our understanding is not perfect, but I don't think that we should, as doctors, discount the distress that some of these patients experience.
Sure, that makes sense and kind of ties what you described earlier.
You got muted there, Slim. Can't really hear you.
Dr. Wood, I think, is raising her hand. Please go ahead and ask your question.
Thank you so much. Yeah, I just wanted to jump on the borderline personality disorder thing because I totally agree with you. I think that, the personality disorder category is just so stigmatizing. And I think, again, a lot of it can probably be explained with trauma. And like you said, threat dysregulation, I think that makes a lot of sense. And if we can approach treatments through a more, biologic way of kind of helping patients with the symptoms, from the top down approach like you're describing, I think that can be a lot more effective. I just wanted to say thank you for this talk, and I agree with a lot of what you say. I too have had a lot of frustrations with the DSM, and I think it really colors everything we do as psychiatrists. And so, And just one other thing. So I know at the beginning of your talk, you mentioned how we're still kind of using really horrifying language like idiots and insane persons. And that was actually just adopted into our state constitution with issue 1 that was passed. And there's a specific clause in there that's saying that idiots and insane persons are not have the right to vote in our state. And I think it's just interesting to see that really is still around nowadays.
Yeah, that's essentially what the Census Bureau report from 1843 was essentially saying, right? Is that that idiots and insane checkbox was used to marginalize individuals, and here it is. Here we are.
Any other questions for Dr. Farooqui? Please raise your hand.
I guess I was trying to. I don't know if you can hear me.
We can hear you, Dr. Libman. Please go ahead.
Oh, Ali, that was a great job. Thank you for doing this. As a retired psychiatrist, I think I won't comment quite as much on the modern stuff of treatment and diagnosis or anything like that. I do remember DSM-3 when I was taking my boards, but the thing that struck me initially was from my dad, who was a physician educated very close to Freud in Breslau, Germany. I heard a lot of these stories, and some of the famous psychiatrists of that period actually taught at my dad's medical school in Breslau, which is a little bit interesting. And one last quick comment about idiots. The Kentucky law today, 2024, today includes the word idiot as an exclusion for people who can't vote. The first paragraph of the Kentucky law excluding who can't vote in Kentucky elections is idiots. That is the specific word. But anyway, thank you.
Thank you.
We still have a little bit of time if anybody wants to ask Dr. Farooqui about questions regarding the presentation or anything else. Dr. Abel raised her hand. Please, I think you can talk. Go ahead.
Can you hear me?
Yes.
Okay, so this is kind of going off of Swing's question. So I definitely agree, and we've talked about borderline personality, that it may be a brain phenomena that's been incorrectly relegated to the category of personality or character pathology or what have you. Any concern that this framework may bring normal distribution of behavioral responses into the realm of pathology and remove accountability from the patient? Or that we could medicalize deviance. I know that's kind of pivoting to like antisocial behavior. And I know that some forensics people have used that term medicalizing deviance, which definitely has some bias inherent in that phrase. But what do you think about that?
What I have to say about that is the context is, I think, very important because if you look at the research domain criteria framework, which is kind of the main framework that the NIH is using, then your environmental factors, along with the units of measure, which is the substrates and the ingredients, right? That's your brain itself. That's kind of coming into play. So the question with deviance is, what is the context of deviance? Are you looking at deviance? Is it a brain-based phenomenon, or is it a phenomenon that is based in environmental gain that is independent of your brain functional and dysfunction? So I don't have a good answer because I think that it's a move in the right direction, but obviously it's not going to be perfect because it's still in an evolution state. I like the fact that it doesn't rely on the paradigms of old. I like that it's a new paradigm and the approach is new. But I actually think it's the opposite will happen. I don't think that this will actually normalize or bring normal behavior into the pathological realm. I think the opposite will happen. I think that it will actually take some individuals with pathology and who have current identified pathological diagnosis and actually help to kind of trim the fat of what we are treating and what we're dealing with. And the example that I give to a lot of folks is the development of anxiety with attention deficit disorder. So if you have, attention deficit disorder, in my opinion, is a trait. I don't think it's a disorder. And in the trait, just like any other trait, like skin color, it will lead to dysfunction depending on your environment, like I mentioned with skin cancer. And so what ends up happening is you have a compensatory response in some of your brain networks, because if you have a dysfunction in your cognitive network, you're going to overburden your other networks that might try to accommodate for the dysfunction in your attention and cognition, which is associated with the ADHD trait. And what that might look like when you are younger is that you are a perfectionist, you take a lot of notes, you color code everything, that you have to keep a calendar that's very rigid and very tight. And as long as your brain is able to adapt to your environment, you're going to do fine. But then as soon as your brain reaches its bandwidth and is not able to adapt to your environment, then you're going to have dysfunction. And that dysfunction might present as panic attacks. You might forget to write down a test date in college and have a panic attack when you walk into class and there's a test and you didn't know that it was not, and then you go to the hospital and or to the ER or wherever, or to a psychiatrist, and they diagnose you with panic disorder. But what actually ended up happening is that you were compensating for mild degrees of cognitive and attention dysfunction. And you always did well in school because you had appropriate and hyper appropriate compensatory responses. And so the symptomatology, as we understand it, of attention deficit never actually presented itself. But when the compensation failed, then what presented was panic. And so now you have panic disorder. And guess what? Treatments aren't going to work because the panic disorder is not predicated on your networks for anxiety. It's actually predicated on your networks of attention. And so you're going to go through multiple SSRIs, you're going to do SNRIs, you're eventually going to rely on benzos, maybe, who knows? But none of those are actually going to work because you are treating the inability of your brain to compensate for the pathology, not the pathology itself. And so I actually think for that the criteria and the framework as and the direction it's moving is going to help identify patients like that. So these patients will not have anxiety disorder, panic disorder, MDD, and whatever. They'll just have maybe some low-grade ADHD, or maybe not even use that diagnosis. Maybe they'll have low-grade executive dysfunction that might require some other treatment that is going to take care of whatever is happening downstream. And so it's kind of like in this, it's kind of similar to, I'm going to use the heart attack analogy again. Chest pain, you should not give morphine for a heart attack. You might need an angioplasty. And so an angioplasty is not a pain relief medication, but it does relieve pain because it stops you from having a heart attack. So that's kind of that's what I think that this framework will allow us to do, is have a better understanding and contextualize the patients from a biological lens.
Dr. Stewart, you're up.
I just wanted to jump in real quick. I really enjoyed the presentation. Great job, Dr. Farooqui. Thank you for a very thought-provoking presentation, and really stimulates my thoughts about, and just what you said about the end. What I just wanted to say was, what I think I'm hearing you say is, for example, with ADHD, it's not specific enough, and what we really have to get down to is the root of the malfunction, which could be a whole lot more variability and a whole lot more complicated than we've previously thought about. And that's where this is leading to much more maybe individualized approaches and identifying specific deficits that before maybe we haven't been sophisticated enough to identify. Anyway, that's it. Your comments. Thanks, man.
No, thanks for saying that. Yeah, absolutely. It's kind of like, it's kind of like if you're only as good as the tools that you have, right? So you can only measure what you can measure. Like, so I treat a lot of OCD, and I hate the Y box and any other tool that I have for measuring OCD because it only measures what it can measure. And so with ADHD, we're kind of, and with any other psychiatric conditions, we're only limited to actually being able to measure what we can. And so but that's might not be the full complete picture because our tools are not developed enough yet to be able to do that. So I agree. I think that that it is more complex, but it doesn't. But I don't think that it necessarily. I think that's actually a sign of hope rather than a sign of anxiety in terms of the complexity of it. Because if we can organize the complexity into a framework that we can then manipulate, then yeah, we can personalize treatments. And we kind of already do that, right? So we already do that with GeneSight stuff. We already do that with a lot of microbiome research going on that I know that you've been involved in the past. And so we're already moving in the direction of personalizing. But I think that this right now is actually pre-personalization, because what I think that we need to do actually before we personalize is actually contextualize and understand what is going on in an individual's brain. It's hilarious when I see because I do a lot of scales in my clinic, and I think it's really funny because almost everybody checks off the ADHD scale. But I mean, come on, attention and concentration. I mean, I'm not going to go back to the slides of this, but problems with attention and concentration are like anxiety related, depression related, PTSD related, ADHD related. And so the tool is imperfect. And so if we rely only on the imperfect tool, then we're going to get imperfect results. And the beauty of, I think, the research of criteria is actually should be empowering to psychiatrists instead of zapping the power away from us. Because what it's telling us is that we are the tool. And so the power to be able to stratify and understand these syndromes falls on us. We just didn't have the arms and the means to conceptualize it and to attack it and to address it in the way that is biologically appropriate. And the biggest takeaway I think from the presentation should be the vocabulary, honestly, because it's you know, I use this example quite a bit. It really matters if this side of your ring finger or this side of your ring finger is numb, because there are different nerves that go there. So it's not enough for me to say that my finger is numb. It is very important for me to know which finger, because they're different dermatomes. It's really important for me to know which fingers, because different myotomes. And it's really important for me to know which side of the finger also, because that's different specific nerves. So if I don't have nerve conduction studies in an MRI, which neurology didn't, then they were hyper specific in identifying where your numbness was because it correlated anatomically and it changed treatment. And psychiatry did that already. And the example that I use for that is syphilis. So paresis, syphilis and syphilitic psychosis, people were in the hospital for that. They were in psychiatric institutions for that. We were able to identify what psychoses were from syphilis versus not and give those people penicillin, and we treated their syphilis, and some of them sometimes got better if we caught it early enough and they moved on. Now imagine giving penicillin to the entirety of a state institution and not being able to identify which psychosis is from syphilis and which is not. The penicillin will work on what, like 20% of the people, and you'll say, oh, penicillin is a cure is 20% effective with an effect size of 0.2 or 0.3 in terms of treating psychosis. And so then penicillin falls into the algorithm of which antipsychotic we would use. But that's crap. Because if we gave penicillin, if we were able to identify which psychosis was syphilitic, which we were back then, and we gave those patients penicillin, all of them got better. And so we've already kind of done that, but the way that we practice has shifted to the point that we're not able to kind of investigate the symptoms as well as we could in order to understand better. And so I don't advocate for system-based approach. I advocate for system-based understanding and then disorder-based treatments. But understanding the disorder has to come from what symptoms you're experiencing, because that's how you understand what's going on in the brain, just like hand numbness. It's a different nerve, different nerve, different nerve. And so it's completely different areas of treatment. And so same thing with the way that we evaluate attention, the way that we evaluate anxiety. We can't just use the word anxious. That's like using the word numbness or using the word back pain. You know, we have to kind of be a little more specific, I think.
I have another question that's related to maybe advocacy efforts. How is the public opinion, the lawmakers can be influenced to kind of shift from that? Last time we were making the DSM, people wanted to, cut out the personality disorders, but they didn't. And I kind of agree with you that we have to kind of destroy it completely and have something new. But when do you think that's going to happen? What's kind of the timeline of that shift happening in your mind?
I think it's because that's such a you have a lot of players, man. So but I think it's already happening. But we have a lot of players and a lot of ground to cover. The reason I think it's already happening is because, you know, the muscarinic agent that recently got approved for schizophrenia, right? That's not called an antipsychotic. It's not classified as an antipsychotic agent. Okay, it's classified as a muscarinic agent, and the approval for it and it's approved to treat schizophrenia. And so you're already kind of seeing a little bit of a shift, right, into the more, you know, just mechanistic, pathological based approach to treatment. And if you think that this is going to be the first medication that does that, you're wrong. I mean, AbbVie already has a muscarinic agent in the pipeline that's they're going to do phase 2 trials on to compete with the Cobenfy or whatever. So the treatments are kind of moving in that direction already, where they're kind of stemming away from this disordered based thinking into the more, like, you know, brain-based thinking. And so the paradigm is shifting. The speed will really just, honestly, I think it'll kind of depend on us, to be quite honest with you, and on our acceptance of the fact that we might need to erase and start anew. More than likely what will happen is there's going to be a marriage rather than an evolution. And then after the marriage, there'll be a divorce, and then you'll be left with the thing that works.
Sounds good. We have one question in the Q&A, kind of who made your beautiful PowerPoint template?
I'll let you guys take one guess, because you know it's not me.
All right. All right. Well, thank you, Dr. Farooqui, for a wonderful presentation, and thanks for all the attendees for your attention and your time. And we'll see you later. This presentation will be uploaded to our YouTube channel for your viewing. Thank you, and have a good day.
Yes.